education, between UCF and Indian Institutes of Higher Learning. We are also the interface between students, faculty, and the Indian American community, and we seek greater and greater engagement across these three principal stakeholders which India Center has. Let me pitch in for a couple of events which are coming down the road. We will have Professor Devesh Kapoor in March from Johns Hopkins, who's going to talk about Indian American diaspora, and he's an authority on the contributions, both political, social, and economic, of the Indian American diaspora, wrote some award-winning books. So he will be here on March 10th, and then we have the distinguished lecture on April 2nd. The CEO of General Atomics, Dr. Vivek Lal, will be here to deliver the first India Center distinguished lecture, and immediately afterwards we would have the India Center annual conference. So please do join us for these events. With that, let me pass it on to Laila to make the introductions for today's event. Thank you, Laila.
Thank you, Yogesh. So I am very pleased to be introducing our guest speaker. We've been keeping him busy. He's been meeting lots of our faculty around UCF campus. And last night he participated in a very lively discussion with our community members in Windermere. So we're getting a lot of interest in his topic. So we are very honored to have Dr. Vijaya Kolachalama here with us. He's an associate professor at Boston University School of Medicine and a founding member of the Faculty of Computing and Data Science at BU. Dr. Kolachalama is a computer scientist with a laboratory focused on developing advanced machine learning and image processing algorithms and design software technologies that have diagnostic relevance. Dr. Kolachalama is a co-founder of CognosGreen, which accelerates dementia clinical trials through AI, augmented participant screening and recruitment. Dr. Kolachalama completed his undergraduate studies in aerospace engineering at the Indian Institute of Technology in Kharagpur and obtained a Ph.D. from the University of Southampton. And he completed his postdoc in health sciences at MIT. He is a fellow of the American Heart Association and received the Young Alumni Achiever Award from IIT Kharagpur. So we are very lucky to have such a distinguished speaker with us today. I'll hand it over to Dr. Kolachalama.
Thank you so much. Hello everyone. Thank you for joining this. There are only a few people here, so hopefully we can make it a little bit more discussion-like as opposed to me just lecturing about this. I think Laila mentioned about this eventful reception that we had yesterday. Some of you were present there, and I've learned a lot during that discussion. So last night I actually changed my slides based on the feedback that I received because it was important to sort of hear the feedback from the community. So today my goal is to focus on hopefully inspiring some of you to really think about AI and medicine by giving dementia as an example. And my content is going to focus on how to really think about not just developing these methods, but also really thinking about how to translate these tools to the clinic, because I think that's kind of really one of the important things, because we live in different worlds. Computer science lives in a different world, School of Medicine lives in a different world, and for us to be able to really bring those advanced technologies and tools to the clinic, we need to start talking with each other, and this is my way, or at least my the stuff that I've done is hopefully one way to do these things, right? So with that, the first thing I also want to talk about, because I have a lot of students here, I think some of you actually asked me some questions last evening as well. What does it mean by doing AI in medicine, right? So I think it all starts from the team, the people, and which is why my first slide is actually about my team. Like usually these things are put in acknowledgements, but I wanted to make sure today I talk about my team first and then talk about what we do later. So as you can see here, I have color-coded based on the expertise of individuals here. Obviously, the first section is actually the trainees in my lab. And I can see here, I have, fortunately, students from different disciplines who are doing research in my lab. Some of them are Ph.D. students in computer science because I have an appointment there. I also have MD students who are in medical school, M1 and M2, which is the first and second year in medical school. They're also part of my lab. And I also have some students who are getting a Ph.D. in neuroscience because we work in neurology. So when I put all these people together, magic happens. Right? That's all I am doing. I'm actually trying to bring these people together. And they are the ones who are interacting, they are the ones who are actually doing the hard work. But I think it's very important to keep this in mind because AI in medicine means we need people with AI and we also need people who have some experience in medicine. So when we put those people together, I think we can hopefully bring some tools to the clinic. So that's kind of has been my focus. And the other important piece of the team that I have, although these are my collaborators, not necessarily part of my lab, are these clinicians who wear different hats. As you can see here, when I say neurology, it's sort of a very broad term, but clearly each of them have different expertise, different levels of expertise. So you can see people who are neurologists, who are the ones who are seeing the patients with neurodegenerative conditions. You also have neurologists, neuroradiologists, who are the so-called back-end physicians who are looking at the imaging of those patients. You also have neuropsychologists, who are also different kinds of experts. They also deal with the patients by administering lots of different tests to understand their cognitive function. And then finally, we have neuropathologists, who are also back-end physicians who look at the tissue samples that are from the patient, right? So we need all of them because all of them provide different kinds of expertise and all of them actually work towards managing the patient, right? So fortunately, I have a lot of people, most of them are actually from the Boston Medical Center, but also places outside Boston. Some of them are actually from the University of Nebraska in Omaha, and Emory University and many other places, because they all, in my opinion, have been the frontline adapters of at least thinking about AI in medicine, right? So that's, I think, another important thing to keep in mind. So obviously, by having all these people, we're asking clinically relevant questions. These are the ones who are teaching us what kind of questions to ask, what kind of things we need to address, because I think yesterday the discussion was about, how can we improve operational efficiency in AI? But clearly, as a researcher, I'm also thinking about how to sort of really ask more interesting or more clinically relevant questions, so that ultimately what we want to do is we want to build these assistive tools that can augment or that can facilitate neurology practice. That's kind of has been my goal. So broadly speaking, our primary goal has been to create a virtual assistant for neurology. That has been our focus. What does that mean? Obviously, neurology is very broad. So within that, we're trying to focus on something which is related to dementia, right? So I want to give you some statistics on dementia. Some of you probably know this, but I just want to give you a sense of why this is a big problem. So it's considered as one of the global public health concerns. So these are some recent statistics. About 50 million plus people actually are living with this condition today as we speak. And these numbers are only expected to increase, primarily because of the fact that we have people living longer, which means aging-related conditions are also going to be on the rise. So the expectation is that by the time in 2030, we're almost going to touch 80 million people. And believe it or not, the end-of-life care cost is actually higher for dementia than even heart disease or even cancer. Because when we're talking about dementia, we're talking about managing the person, starting the time when they are diagnosed, all the way until they pass away. And that whole process is very, very complicated. It's not just the doctor seeing the patient and the doctor treating the patient, it's the entire family involved in treating this person, right? So if suppose, for example, if somebody has a fracture, they complain, they have pain, they see the doctor, they get a cast and they recover. But if somebody has cognitively abnormal function, then you're dealing with them every day, day in and day out, and it becomes a very complicated challenge, and it's really tough on even the family members, right? So it's a very interesting problem and a very complicated problem, and also the toll is very high, relatively speaking. When I say dementia, I think I want to make sure people understand here that it's a very broad term, right? Dementia actually is a very broad term, or an umbrella term, used to describe various different neurodegenerative conditions, including Alzheimer's disease. Alzheimer's disease is obviously the most common cause of dementia, but Alzheimer's disease is not dementia, right? So Alzheimer's disease is one way somebody can get dementia. In fact, Alzheimer's is actually even not part of normal aging, something which is abnormally that is happening in the brain that is causing dementia. There are other forms of dementia, so people with Parkinson's disease can get dementia. People who have vascular conditions can also get dementia. In fact, in India, since we are here at the UCF Center, one of the most common causes of dementia is B vitamin deficiency. Believe it or not, it's a reversible condition, but a lot of people, in fact millions of people in India have B vitamin deficiency, which can also cause dementia. So depression, anxiety, all these different things can cause dementia, right? So when we talk about dementia, we want to talk about this very broad umbrella term, which is about memory decline, cognitive dysfunction. Since I'm here at the India Center, I also want to talk about the actual landscape of dementia in India and in the US. So this is a slightly older article published in 2015, but you can see the numbers here which are very sobering. These are the statistics which are sobering statistics. So the US obviously is also having a shortage of specialists. We have about 5 neurologists per about million. But in India it's even worse, which I think is somewhat expected because we have larger population, but also the number of physicians or the number of caretakers are less. But one thing that I think struck me when I read this article was that about 1 billion people don't even have access to a neurologist, which is crazy if you think about it, right? So most of these people are living in remote places where they don't have access. So what do we do about these things? Hopefully we can, bring AI there. One of the common things that is done for looking at dementia-related conditions is an MRI. And clearly here we are having about 40 MRIs per million people, but in India it's 0.4 per million people. And it's not easy to get imaging done. And imaging is one of the most important data modalities to actually look at what's actually happening in the brain. And the projections are kind of interesting because if you look at the actual numbers, they're in fact almost the same. There could be many reasons for it. I mean, clearly we have better ways to diagnose the condition in the US, but it may not have so many nice ways to actually diagnose the condition in India, which actually means that most people actually are left undiagnosed, which can also cause big harm to the society and also the families. Economic burden, again, is also something to consider and very, very important. And these numbers are also staggering if you think about it. So $320 billion is the expected cost burden today in the US for those people who are suffering from dementia. Obviously, 5 billion is still a very big number in India. I think these are, again, projections based on what is happening today. I was reading this article by the World Health Organization, and they highlighted 7 different aspects as part of their global action plan of tackling dementia. And as you can see, number 4 is actually diagnosis. Yesterday, some of them said that we don't need any expertise on decision support, but it turns out it's not only the most important things to do because you need to accurately diagnose the condition, but at the same time, I was also reading a statistic which says that diagnostic error is actually the 4th leading cause of death in the United States. So people can actually make mistakes in terms of making the right diagnosis. So clearly, we also need some help in terms of doing these things better. Some additional statistics. So here again, I'm talking about the lack of expertise, right? Neurology profession is a very hard profession. So you got to imagine a doctor seeing these patients who have these memory conditions, psychiatric conditions, day in and day out, talking with them, talking to their family members. It's draining. It's draining on them. So 5 of my colleagues in the last 2 years have left the profession because they were burnt out. Because at the same time, it's actually not that economically a great job, because relative to, for example, orthopedic surgery or interventional cardiology, neurology is not going to make that much money. So there are all these other factors that are causing the issue or actually blowing up the issue. So what are we trying to do? We are focused on basically building these AI-based approaches that can use routinely collected clinical neurology workup data to then create these assistive tools that hopefully one day can be integrated in a clinical setting. So what we are talking about is looking at different forms of data. When you look at a neurology workup data, you're talking about patient history, lab values, medications, those cognitive tests that are done to understand their condition, MRI scans, CT scans, EEG recordings, all this stuff is actually done to understand the condition. And what we are trying to do is figure out ways to build these systems, build these multimodal AI systems that can process all these forms of data and then come up with meaningful ways to sort of assess the person's condition. So that's kind of really is the computational challenge. A very exciting challenge because there are different modalities of data. So you need to figure out ways to sort of process all these things, which means you need expertise in not just in machine learning, computer vision, natural language processing, and all those things put together. And only then we can create these multimodal AI systems. So, and we don't end there. In fact, we just begin by creating these models. The large piece of work we actually do is after we build these systems, because we need to make sure we validate them. We also bring experts to understand how these things work. We also think about how exactly these things can work in a clinical setting. So all the AI part is about 30 to 40% of our work, but a large part of our time is actually spent on validating these models, and that's what I want to focus on. Because especially if you're a pre-med student, you might be wondering, you know what, if I know computer programming, or if I don't know computer programming, how do I actually make a contribution here? The reality is that there is a lot of stuff that we have to do to make sure you're actually validating these frameworks. I'm happy to pause at any time if you have any questions, but I'll continue until you say so. There's one more use case I want to talk about, which I think is also very, very, very important. I don't know if you're following the news, but in the last 2 to 3 years or so, there were 2 drugs that were approved by the FDA, actually 3 drugs by the FDA, focused on Alzheimer's disease. They are monoclonal antibodies that are targeting these amyloid plaques in the brain that were approved by the FDA after many, many, many decades of failure in the field. So a lot of big pharma companies have actually even shut down their neuroscience units just because things were not working out. And finally, due to public pressure, despite the fact that the FDA committee, 9 out of 10, I think, people rejected the approval, FDA still approved the drug because of public pressure. So that was the amount of pressure the society has created, and in fact, that's the reason why dementia is such a big problem. So anyway, the drugs got approved, and after the drugs got approved, the floodgates have opened. So now many pharma companies are coming back and to look at drug discovery, coming back to look at drugs for clinical trials in the context of dementia and broadly neurodegenerative conditions, and they have a big problem. The biggest problem they have is, how do I get the right patients to do clinical trials so that I can actually be successful in these clinical trials? So patient recruitment is a very, very big challenge, and billions of dollars are spent on identifying the right patients for these trials. So what happens if you see on these things is that, so for example, let's say in a neurology clinic, there are 100 patients who have been diagnosed, let's say, with dementia. And a pharma company comes and says, okay, you know what, I need these 100 patients because I want to make sure I enroll them in a clinical trial. And it turns out that out of these 100 patients who are clinically diagnosed with dementia, only 12 patients make the cut. And the reason is because there is an 88% screen failure rate, which means the clinical diagnostic criteria does not necessarily meet the clinical trial enrollment criteria, because of which the pharma companies are spending so much more money to get so few patients for their trials, right? This is a huge challenge, and it's actually worse in the context of neurology. It's actually even worse in the context of dementia. So these are opportunities where I think you can think about how to sort of meaningfully contribute towards not just patient care, but also sort of really thinking about how to improve efficiencies in other aspects which are related to patient care, right? Clinical trials is one of the most important things. Unless you do a clinical trial, a drug won't get approved. If a drug doesn't get approved, there is no therapy. The patient is going to suffer, right? So all these things are part of the ecosystem, and you have to think about these aspects. And I think we have been kind of really been educated on all these things from all the experts who actually are seeing the problems, right? So this is another opportunity where AI can potentially help. Imagine again, there is a system where the AI is looking at all this multimodal data and trying to identify who might turn out to be screen positive, right? So that's another way we can contribute to the society. Sorry, you have a question? Oh, sorry, okay. So where are we starting? So the first thing we do is we spend 70% of our time, like I said, collecting data. So what you're seeing here is access to multiple different cohorts of data coming from multiple different places around the world. And we have had collaborations like I noted before in the slides, where the data is being collected from all these different sites. Most of them are research sites, some of them are clinical sites. And we are basically trying to put all these data together in our database, right? So the first thing we have to do is we have to figure out how to collect this data. what forms of data is available. Sometimes data is missing. In fact, most of the times data is missing. Some forms of data is missing. So how do you harmonize all this information? What you're seeing at the center here is something called as a Framingham Heart Study. Anybody heard about that, by any chance? So Framingham Heart Study is one of the longest and oldest trial study that is happening in the country. It started in 1948 and is managed by BU. And what they did back in the day was they were observing the people who are dying of heart disease unexpectedly. So they wanted to recruit people who are living in a town setting and then observe them over time. So this became an observation study since 1948. And because of Framingham Heart Study, the term risk factor came to play. So the term risk factor was coined because these people were recruited from the town of Framingham and they were observed over many, many decades. So the risk factor term was introduced by Framingham Heart Study. The fact that smoking causes cardiovascular disease, the fact that hypertension or high blood pressure causes cardiovascular disease is because of the Framingham Heart Study. Since 1999, they started recruiting participants also to look at the brain health. So we have this very large collection of data, a community cohort setting, rich collection of data. When I'm talking about data, I'm talking about all these different modalities put together so that we can sort of really think about model generalizability, model adaptability across many different and across many diverse populations. So a large part of our effort has been to collect all this data. Some of it is open source, some of it is closed source, but I think we have had these collaborations that allow us to do all these things. And then I also want to talk a minute about, for those who are not familiar with imaging. So when somebody says medical imaging, it's a very broad term, but there are many types of imaging. As you can see here, I just give an overview. There are 4 kinds of things that I'm showing here. The first is a CT scan, which I'm sure you're familiar with. What does it do? It basically looks at structures like bone. So it's like heart structures, right? So, and also those vessels you can see in those images. It allows us to detect certain things like fractures, injury, head injury, bleeding, and those aspects. So on the right side you're seeing is something called as an MRI, which is basically looking at soft tissue in the brain, which means if somebody has some atrophy, which means loss of content in the brain. So MRI is used for certain other things, especially people with Alzheimer's have atrophy, which means loss of content in the brain, structural loss in certain regions in the brain. So that is something that is usually observed on MRI. And the bottom 2 are these functional MRIs, which are looking at certain activity in the brain. Like what you're seeing here is the deposition of a specific protein called tau, which is connected to Alzheimer's, and that can be visualized using PET imaging. And then finally fMRI, which is a functional imaging, which is also looking at oxygen content in the brain, right? So broadly speaking, the first 2 on the top are structural imaging, which deals basically with the structure of the brain. And the bottom 2 are basically functional imaging, which also looks at the activity in the brain. So these are all the different things you actually need to know and understand to figure out how to better diagnose the condition. Not just dementia, Alzheimer's disease, and related dementias, right? So it's a very broad thing. So once we have all the data, then we start the hard work. So we have to do all kinds of image registration, which means you got to imagine, if I have 100,000 MRI images, and each MRI image is a volumetric image, which is like a 3D, which means it has slices in all 3 dimensions, talking about axial, 100 slices, coronal, 100 slices, sagittal, 100 slices. So 100 by 100 by 100 is the image. It's a very large volume of data for a single person. If I have 100,000 of those, then good luck for me. I have to somehow figure out how to manage all this data, right? So we have to build automated pipelines to sort of take these raw MRI scans, figure out ways to think about registering all those images. Because if I have one image oriented this way and the other one this way, and if I throw that to any machine learning algorithm, it's not going to do great. So we have to figure out a way to sort of align them. Registration is a very key component. Checking the quality, sometimes some images may have loss because the scanning was not done properly. So you have to figure out ways to evaluate those things in an automated way. If I have 100 cases, I can spend like a week or 2 to process them. But if I have 100,000, there's no way I can actually do them manually. So you got to figure out how to process them automatically. And that's kind of really what I'm talking about here. And after that, we do other things like selecting the regions of interest, normalizing the images, segmenting the regions of interest, and so on and so forth. And then comes the AI. AI only comes after that. But a lot of stuff is about pipeline development. Just to give you an example, what you're seeing here is basically one slice of the image in 3 different views. This is the frontal view or the axial view, coronal view. And this is the side view, which is called the sagittal view. And the third is the top view, which is the axial view. So this is my source image. So what I have to do, in every direction possible, I have to somehow figure out a way to align that to some kind of a template. And I have to do that slice by slice, plane by plane, for all the cases, for all the 100,000 cases. Hopefully that's going to take a few weeks, but we need, for that, advanced computing power. That's why GPUs are required. And then, after we do that, we have to also think of ways to look at what's inside the brain, which means, what's inside the skull, because this bright part around it, it's too shiny, and it also interferes with signal processing. So what we have to do is figure out a way to automatically strip the skull, then only see what's inside the brain, right? So this automated technique also has to be applied on every slice. So this is skull stripping, which is another thing that we have to do. And in fact, we have actually built a deep learning pipeline just to perform automatic skull stripping on the entire MRIs. So after all this work, then comes those questions, right? So here, one of my main, what I'm showing you is a paper that was published in a journal called Brain, which is the top journal in neurology, where one of my PhD students, Shamran, who's now at Microsoft, came up with a fully interpretable framework that basically takes these MRI scans and then asks the simple question. Given these MRI scans and basic demographics, can I identify if the person has signs of Alzheimer's or they have healthy cognition? So one of the first things he did was he basically created something called the fully convolutional network. That is a variant of something called the convolutional neural network. I'm not going to go into the details of that. Where he basically created this efficient neural network that takes these volumetric patches that you're seeing of the raw MRI scans and outputs these volumes and creating heat maps that can nicely highlight subregions of the interest in the brain that point to high degree association of disease risk in that region. So by doing that, we're actually not only trying to assess who has Alzheimer's, but also identifying ways to create interpretable heat maps that can point to the region of interest that points to the disease. So in this way, we're trying to not only build a model that can be predicted, but also be interpretable. Because physicians want to know. Physicians want to know what's actually going on. So they want to see how is the model doing and what is the model actually doing, which means we have to figure out ways to create these interpretable techniques to assess the pathology of interest. So this was the very first question we asked, which is, okay, given a data set, can you say if the person has disease or not? But then as we started talking with the neurologists and the other physicians, our sophistication of our questions advanced, right? So clearly, if you look in a neurology clinic, nobody asks these binary questions. No doctors, is going to ask a patient, okay, this person has disease or not, right? The questions are more complicated. So if you look at here, the question we asked was a slightly more sophisticated question than previously, which is, given a patient data, which is multimodal data, is this person having healthy cognition or mild cognitive impairment or dementia? And if this person has dementia, then is it due to Alzheimer's or due to something else? That's a little bit more clinically oriented question because we want to follow how we can align ourselves to create these models that follow the clinical setting. So here, we also looked at thousands and thousands of cases from multiple different cohorts. And as you can see here, some of them were diagnosed with healthy cognition, some of them had mild cognitive impairment, which is basically a stage before somebody can get dementia. And then obviously about 2,000 or so cases have dementia, and some of them had Alzheimer's, and some of them had non-Alzheimer's dementia. And we again built these frameworks to combine all this information, and then we created some other interpretations. So what you're seeing here is just basically a rank-ordered list of factors that the model identified that could actually be predictive of the condition. So on the left side, what you're seeing is this first fast question, which is, given the patient, let me assess that person along the functional spectrum, which is healthy cognition, mild cognitive impairment, dementia. But once we know what's happening along the functional spectrum, what is actually causing that condition? Is it due to Alzheimer's or is it due to something else, right? So as you can see here, the model was able to sort of really rank order all these different factors that affect the condition. And MRIs, interestingly, played a role, more importantly, to differentiate those patients who have Alzheimer's versus those who did not have Alzheimer's but still had dementia. This is again a way to sort of create these interpretable machine learning frameworks to sort of explain what's actually going on in these patients, right? So one other thing which I don't know if I got a chance to talk before, but unfortunately, the gold standard or the only way to confirm if the person has Alzheimer's is during postmortem. But we cannot do that in patients who are alive, right? But it is still the accepted gold standard. So one of the things we did was, we had about 100 or so donated brains, people who have died from, they donated brains to the VU Brain Bank. So we looked at the pathology of those individuals and identified regions where there were pathology, and we graded all those different regions with the help of the neuropathologists. And then on these people, we had data when they were alive. So what we then did was, we took our model that was trained on some other data, and then we tested it on these 100 or so cases to identify what we can do on those people. And what you're seeing here is basically the association of the model with the degree of pathology that was observed post-mortem. Again, a very great way to computationally validate. In fact, not just computationally validate, but validate our computational model predictions with ground truth or a gold standard evidence that is only available on, unfortunately, post-mortem conditions. But at least this is one way for us to sort of really think about validating our models. And I also talked a bit about interpretability. So what you're seeing here is a case from the Framingham Heart Study. This is a brain that was autopsied, which means the person died, and then the brain was analyzed in different regions. And what you're seeing here is the same interpretable heat maps that we created using MRIs. We overlaid them on the MRIs, and we observed that there was a high degree of correlation of those disease areas of risk with the actual pathology observed post-mortem on that same patient. Again, these things were all important to validate, right? So these are some of the things to keep in mind, because it's not just about fancy AI model development. It's a lot more things you have to do to make sure you're trying to actually translate these tools to the clinic. We did all this. This paper was published in, the one before was published in the journal called Nature Communications, which is a very prestigious journal. We were very excited, but then I started to talk with a few practicing neurologists who are not in academic medical centers. And they said, Vijaya, we don't do all these things. This is of no value to us. So in fact, I'll tell you what actually happens in reality. So this person gave me a very nice lecture of what actually happens in a neurology setting, especially in the context of dementia or cognitive impairment, right? So how are neurologists evaluating patients today? A patient walks into the clinic with a family member, typically with a family member, with a chief complaint. They call it as a chief complaint, which means the family member says, you know what, this person has been forgetting, my dad or my mom has been forgetting where they kept the keys, or they didn't know where they were going, they forgot to turn on the stove, etc. We've been observing this for the last 2-3 months. So that's a chief complaint, involving obviously memory-related issues. Then the neurologist then gathers information, such as demographics, their history, their medication, what they have been taking, etc. It's an interview process that's happening, right? So, and then they slowly started administering some tests like physical exam, neurological exams, functional exam, and sometimes they ask them to get an MRI. With all this data, the neurologist effectively becomes a data scientist, right? Because they're trying to figure out what exactly is the problem, which means first what they do is they evaluate the patient's cognitive status, which is healthy cognition, mild cognitive impairment, dementia. And then, after they know where the person lands on that spectrum, they understand the underlying cause of dementia. And that could be many factors, like I told you before, right? So vitamin deficiency can cause dementia, Alzheimer's can cause dementia. And oftentimes, it's actually multiple factors causing dementia at the same time. So it's more complicated than just saying, oh, Alzheimer's or vascular, right? It's a lot more complicated than what I think people have done so far, right? So this is the reality. So with this as the quest, what we did was, we again started going back to data collection. We collected data from a lot more patients here. So we're talking about here 50,000 patients collected across multiple different cohorts. This data collection itself took us more than 1 year. And then finally, we were able to sort of really address a clinically relevant question. What you're seeing here is basically a list of all the different things, which are a lot of clinical terms here, but I just want to take a minute to explain. Again, healthy cognition, mild cognitive impairment, dementia. But these are all these different factors that are going to cause dementia. And sometimes multiple factors can also cause dementia, right? So these are some of the things that the neurologist is actually evaluating to then make sure that the patient can actually get the right care management strategy after that, right? So This paper was published in Nature Medicine, which is again a very good journal, which I think appreciates the fact that we are not only building these AI methods, but also we are thinking about truly addressing a clinically relevant question, and not only building the method, but also going systematically to validate these methods across many different ways, using many different ways. So some of the results are pretty much about how we are trying to pursue this idea of validating the models. What you're seeing here is just basically the fact that our model was not only able to detect dementia, but also early detection of dementia. So we were able to sort of somehow, for some people, we were able to also identify the signs of early cognitive impairment, and the model was able to actually do that pretty efficiently. And then we also did this idea of, for the first time, an AI framework was able to identify mixed dementias, which means conditions that are occurring at the same time, co-occurring factors, right? So this is another thing that was also a big highlight in the work. And then these are all the plots that I just want to go quickly, just to make sure you understand the pain it takes to sort of really validate these methods. What you're seeing here is just basically association of these models with something called as biomarkers, which is some of the clinically acceptable factors that I think are going to tell an individual what kind of condition they have. So we did a lot of work to associate the model with all these biomarkers. And then finally the postmortem data, like I said before, which also showed that our model was able to sort of identify the true pathology in those patients ante-mortem, because before they died. And I want to spend 1 minute on this thing, which is on the key slides, which is basically the icing on the cake. So what we did was, we recruited about 12 neurologists and 7 radiologists. And what we did was, for each of those clinicians, we gave about 100 cases and asked them to sort of really do the same thing that the AI model was doing. So what they did was, they looked at each case, they sort of then rank ordered those 13 different conditions, and gave us back the reports on all these 100 cases. And what we are showing here is a result which says that in a randomly selected of a subset of 100 cases, neurologist assessments augmented by AI exceeded neurologist only assessments by about 26%. So what we are showing here is a true AI augmented assistive tool that can hopefully help neurologists, right? So this, I think, was one of the most important things that we have done, to sort of really bring that tool to the clinician and asking the clinician to actually use this tool. And then we showed that by using the tool, clinicians were actually able to do better their job, which I think is significant, right? So these are some of the things we have to think about, right? So essentially, a clinician using AI hopefully will be doing better than the clinician who is not using AI. With that, I just want to quickly summarize what our work is. So these are some of the papers if you're interested. It's basically a gradual increase of the complexity of the work over time. You were able to sort of really understand truly what is the clinical question, how do you actually create methods that can fit the science. Right? It's not just taking a fancy neural network to just work on a question. So we are really deeply thinking about the questions, and we're also creating a lot of partnerships. So that's another important part, right? So without data, we are nobody. So it's important to think about how to collect data that is relevant to your specific task. And we have established some partnerships across different places. Some of them are in Boston, one is in Arizona, Illinois, Stanford. So there are a lot of these people who are collectively interested to sort of promote AI, and which is why we were able to sort of put all these pieces together. That's actually the hard work. And then path forward, at least for the people who are here, my only thought is that for you to think about AI in medicine, you also want to think about data. Clearly, if you don't have data, you're not doing a good job of actually building AI. And research here that is happening in the US can actually also help things that are happening in India too in some ways. Because one of the interesting things is that a lot of people who migrated from India, they were born there, but they have lived the life here. So there is an opportunity for us to actually look at these patient populations to see how we can sort of translate the tools to specific individuals who are living here, with the hope that these things can serve as examples as to what's actually could happen in India. So there are ways to actually also work here within the community to see how we can translate these tools. Our software is basically, EHR, it's EHR integrated, so which means people who have these healthcare systems can actually directly work with this data. And yeah, with that, I want to conclude. I just have like 2 fun slides just to talk about it. So one of the slide is about my hero, Isaac Asimov. Anybody knows him? Anybody has read any of his books? Raise hands, please. Foundation series, right? iRobot, right? Fun fact about Isaac Asimov, he was a professor of biochemistry. Out of all the subjects, he was a professor of biochemistry at DU. And then he started writing books and started making a lot more money, so he left BU. But that's a fun fact. I did not know that until I joined BU. And he was my hero. I mean, all the books, all the movies, iRobot, anybody have seen that movie? That was based on his book, iRobot, actually. The laws of robotics, the book actually talks about that in the Foundation series. So he was a great science fiction novelist, and inspired many young people to think about space, think about life outside the Earth. But anyway, the fun fact was that the dean didn't like him not doing research, so she kicked him out. But anyway, finally, I want to thank my sponsors.
Thank you, Dr. Kolachalama, for such a lucid exposition of complex scientific problems at the interface of multiple STEM disciplines. Before I want to introduce and thank Professor Dinesh Singla, who is here to moderate the event today. Professor Dinesh Singla doesn't need an introduction, but if I introduce him, it would take me a session itself. But he's a professor of medicine at the Burnett School of Biomedicine, Biomedical Sciences, College of Medicine, and University of Central Florida. Professor Singla's work is at the intersection of multiple disciplines concerning stem cells, heart failure, diabetes, inflammation, and cardiac regeneration. He has got multiple grants, published a plethora of stuff on all across cardiology issues, I guess, if I can put it like that, being a social scientist. And please forgive me for that. And it is over to you, Dr. Singla. Thank you so much for helping us out. Really appreciate it.
Thank you, Professor Joshi, for your kind introduction. I think I'm a very small guy. So, but anyhow, so your talk was so outstanding. I think it has might have opened hundreds of questions in different minds, especially young people are very smart. And as I know, even few Indians are very interested in AI and in medicine. The young kids, even my son also started it and he published a paper. Then he said he don't want to go to medicine, but he does sell AI and other stuff. But with that, couple of questions I have before I give to the audience. Like with your tool, are you asking neurologists to use your tool to diagnose the patient? Don't use this tool, don't use any other tools such as MRI, CT scan, or other like MRI blocks, test, and other things. Or use only AI and diagnose and give them the medicine, or this will be used as a additional tool compared with the existing tools.
Yeah.
So what are your thoughts on that?
Well, I mean, hopefully people can hear, but I think for the
Yeah, so let me be very clear. I think we need physicians. We need more of them. We need as many as possible. So I don't think this tool is going to replace the clinician and should not. I'm only talking about creating assistive tools in practice. And also, one other thing I want to point out is that by the time a patient goes to a neurology clinic, sometimes it might be too late. So we need these tools to be sort of installed upstream in the cycle. At the end of the day, the way I see it, and in fact that's how so far we have done, is we need all the data that is being collected, including MRI scans, including CT scans and all that. But there is a way for the physician to get a second opinion. Because ultimately, the physician is sitting by themselves, trying to figure out what's going on. And sometimes it's actually good to get some help. So we are trying to think on those fronts, where this could be a truly assistive tool as a second opinion. And like I showed in one of the slides, by using this tool,
the neurologists are able to better diagnose these conditions, but we are not trying to replace them. So I think I have to be very clear on that. In fact, I would encourage people here in female, please become doctors because we need more of you.
Okay, the second question is, I'm not a neurologist. As far as I know, the dementia starts way early than you explained.
Yes,
after
absolutely.
Dementia starts with aging. In fact, after 50, 100% or 80% people are undergoing through dementia with over age. Age is the biggest challenge and effect in dementia. On the top of it, in addition to what you mentioned, there is a drug-induced dementia, there is a diabetic dementia, and a number of other, now there is PTSD and also on are going through dementia. If your tool is going to detect the early dementia, or you're developing a different type of AI tools which will be a age-specific or a disease-specific. So the way you explain it sounds like a very general dementia tool.
So let's not think about what the tool is doing, but let's think about where is the patient being seen in the clinical world, right? So there are different kinds of doctors. The first doctor a patient probably sees is a family medicine doctor or a primary care physician. If that thing happens, then they maybe get a referral to a specialist like a neurologist or a neuropsychologist, right? So in the spectrum of this care continuum, most of the times the patients are seen by this primary care, right? So what we are trying to do is we're trying to create a tool that can emulate a neurology setting, but hopefully can be installed in the upstream setting as well. So our tool has the flexibility to work even if, for example, one data modality is missing. So for instance, let's say there are two patients. One patient has history, lab values, MRI scans, neuropsych tests, everything done, and our tool is capable of processing all that information. But on the other hand, if somebody didn't get an MRI because they may have a pacemaker or something, then our tool should not fail. Our tool should actually be able to also take whatever is available to make the assessment. So we build that flexibility in mind so that this tool can be useful in a neurology setting as well as in a geriatric medicine setting or even a primary care setting. Right? Because whatever data is available, you can feed it into the tool and it can assess or at least provide these differential diagnosis. It's not just about dementia, right? It's also about what is causing dementia. So we're trying to provide those things as well.
Fantastic, very nice. On your last question, let's say your tool is available on the nowadays, because once you make the tool, companies will buy it maybe from Amazon or like a tachycardia, some cardiac machines are available for $99. You can do at home. Let's say tomorrow your tool is available in the market and everybody can start detecting dementia at home. So do you think people will having a fear, oh, I have a dementia, I'm going to develop Alzheimer's disease tomorrow? Or how you will be educating the community or public, your tool is reflecting what kind of comfort? Are you keeping those kind of just a general public things in mind? Because I know if once somebody says you're having a cancer, once a person's depression level goes significantly higher, person is all over the place. If we say this is now, I think majority of people don't even know after 50 they're having a dementia. Well, they think dementia is something which you need a disease because they don't know if forgetting a small thing. Everybody is doing it. And I am now developing with age, saying, oh, I am forgetting certain thing, a certain signs of dementia. If I did take your tool and start detecting it, it wouldn't be scare me. I'm going to definitely develop Alzheimer's disease after 5 years, 10 years. Are you going to do some guidelines for those things too?
First of all, I'm not going to make it public. I don't think that's a good idea. But at the same time, I think you're touching on a very interesting and sort of a philosophical point. So, what is better? Diagnosis or early detection is better, or no diagnosis? So that's a very ethical question. I don't think I'm the right person to answer that question. But there are cases where people have not been diagnosed, especially in India, where you don't have a specialist and they're going through their life, and sometimes they may not live longer because of that. So I don't know what is right, what is wrong, but clearly both have some advantages and maybe some disadvantages. But clearly the tool that we are building are more clinically oriented, so it's, I think, very hard for some create this tool or provide this to a person at home, because these are very nuanced things. Like for instance, if somebody is having, let's say, depression or anxiety or something, there may be certain things that you could potentially assess at home. But we're talking about very, specific pathologies that I don't think you can actually get access when you're at home. Right? So you need extensive testing, you need those expertise, you need that data to be able to do those assessments. So clinical tool, not at home.
So I think topic is so interesting, I can keep talking all the day. So this talk was so motivating too. So with that, I will ask you guys to ask the question. Please feel free to ask any question you have.
So may I ask you to both sit, and then you can use one of the mics and I can use one of the mics to carry it around. So please have a seat, both of you. Thank you so much. Okay.
So I have a question. You mentioned your students working for Microsoft.
One of them graduated, yes.
Yeah, so what kind of work do they do at Microsoft? Like, is it Microsoft, or is it for the Gates Foundation?
So he's not working at Gates Foundation, he's working at Microsoft Seattle. Right now he's in the applied science division, which is, I think, focused on many different things, including some health aspect, but it's not necessarily Alzheimer's or dementia. But when he was a PhD student in my lab, he was the one who designed some of these machine learning methods. But after he got his PhD, he got recruited by Microsoft and is now within their applied science division. What kind of projects he's working on? I don't know. I'm sure it's something to do with science.
Hi Vijay. Hi Vijay. I'm Prabhat Singh. I'm CTO
with Avista.
Hi.
And I'm from KGP, so you're KGP.
Nice, which year?
2007.
2007, okay. I graduated in 2002. I'm older, as you can see.
So my question is regarding multiple areas where AI is making an impact in healthcare. Things like second opinion. Do you think that AI can create a second opinion marketplace?
Well, that's kind of some of the things that we're trying to focus on. I think replacing clinician or talking about clinicians losing their job should not be the discussion, should not be the topic we should talk about. I think it's just unfortunate that some people talk about it. I firmly don't believe in it at all, because we need more of them. Right? We need more radiologists, more neurologists. Right? Why the heck do we want to replace them? It doesn't make any sense. So how can we make their life easy? Clearly, there are so many things we can do. I think yesterday we were talking about the burnout caused due to the excessive amount of paperwork that is involved in processing any of the patient level claims and so on. That's an operational efficiency that we can bring. AI can definitely help there. But I don't see why AI cannot be a second opinion provider. Because it is happening. I mean, I think not every city or every place in the world actually has the neurologist or the available expertise, right? So Orlando, we are spoiled, we have really amazing healthcare institutions. Boston, same thing. But I don't think it's the case everywhere in the world. So second opinion is not a bad thing to have. So in fact, today, as we speak, the term second opinion came because doctors actually talk to other doctors. So it's not new to anybody, right? So I don't think it's far-fetched of an idea to think about AI as a second opinion.
Can I supplement that?
Please go ahead.
So do you think that AI can create a standard, because the whole need of second opinion comes because human to human, of course, like doctors are trained and educated, but there's a lack of some standard.
Maybe because of insurance and carriers and provider techniques and terms used at different places. But somehow physicians often disagree with some other physicians in different point of time. Can AI create a standard in terms of communication, interpretation, inferencing and all that?
I think it's fair to say that AI is going to make the same prediction whether it's 12 a.m. at midnight or whether it's 6 p.m. in the evening. There is a standardization that is happening, but depending on the physician's level of tiredness, maybe they may think differently. So I would argue that it is possible for AI to standardize some of these things. In fact, even more so than you could think. Whether that standard will be acceptable by the clinical community, we'll have to see. Whether AI truly is going to serve a second opinion, we'll have to see. But ultimately, the decision is with the clinician. So we should not change that. The only thing we can do is provide tools. Like for instance, think about it. Let's say, why is the physician using MRI? Why? It's a tool. If without MRI, they can still make a decision, but they still use MRI. So the same way they can use AI.
In 100
That's
years,
how I'm seeing it.
In 100 years, do you think like AI will be autonomous doctor?
I don't think it'll take that long. I think we're coming to it pretty quickly. But I don't think we need an autonomous doctor. Why do we need an autonomous doctor? Because ultimately, it's the touch, it's the final interaction that I think the doctor has to do with the patient. If not, then there is no part of being a human, right? So I think ultimately, doctor will be the final decision maker, but I think a lot of things can happen to make the life easy for the doctor.
Good afternoon. Thank you for your talk. It was wonderful. I have a couple questions. First of all, I really want to know what kind of data you had to use to train the AI. You talked about patients who were diagnosed like after their death. So you said that you had data like from their lifetime. So what kind of data were those that you had to feed the AI in terms?
Yeah, so we have been collecting data from electronic health record systems. So, for example, you think about a patient walking into a neurology clinic. Starting from that time, the neurologist is collecting a lot of information on this patient, starting from their patient demographics, age, gender, ethnicity, so on, to their personal history, family history, medications, lab badges, which means some blood tests that are done, MRI if it is done, EEG recording, CT scans, all this is data. So we've been collecting all this data and building these AI frameworks that can process all this data. So this is the data we are collecting to train the models. What we are doing with postmortem data is we are trying to predict the condition, and then we are seeing if that prediction actually prevailed in that patient by looking at the pathology of that patient. Right? So pathology data is only used for validation, but not for training the model.
Also, I want to know that what kind of user interface does this AI have? Like you've already mentioned that you have physicians who have used it and then given you feedback. So what kind of, is it like a software, or do you have to input patient information and then AI gives you an answer? How elaborate is the setting?
It's both. I mean, it's a software. It's a web-based software where it is integrated with the EHR system, so we can pull the data of the patient into the software, and then the software is easy to use, something by the physician where the physician can see the patient information and the predictions in the report. And at the same time, it also gives them the opportunity to add or remove some information. So it's kind of both in some ways, right? So ultimately, we are providing this in the form of a simple software that can be visualized, the patient's report can be assessed, and all the data related to the patient can also be visualized.
Okay, you mentioned, sorry if I'm taking too long. You mentioned that the percentage of specialists, especially in somewhere like India, it's very rare for someone to have access to a specialist, neurologist. So since you addressed that in your presentation, how does your AI going to address that issue if you take this to India, and how do you plan to promote it?
That's a great question. We're not there yet. I mean, I want to be there, but I don't think I'm there yet. I think what we are hoping is that if, let's say, imagine an AI system that is built on 1 million patients or even more. the AI system would then have the capability to understand across many different conditions, and even with limited amount of data. I mean, if you're talking about, if you give AI a lot of stuff, it's going to do great. But if you only give, let's say, a portion of stuff, it may not do that well. But if you also train a model to learn from millions of cases, then even with some limited information, it can do a slightly better job than hopefully a specialist, or at least with a specialist, it can also do a better job. So maybe in the future, a few years from now, I can see an opportunity where these tools can be utilized in the form of a telemedicine setting or a telehealth setting, where somebody in a big city like Delhi or Bombay is monitoring these tools in a telemedicine sense, where somebody remotely is actually getting the data and then somehow analyzing these things. But we're not there yet. I think there are different problems that I think we are trying to address. But ultimately, bringing these tools to places which are under-resourced, I think is one of the most important things we can do.
Thank you so much.
Yes.
Okay, thank you. So I was wondering how translatable this tool was for other neurological conditions, or for example, because it was trained on a lot of structural imaging, such as MRI and PET scan. So for example, like brain cancer or some other kind of neurological condition.
We're not there yet. I mean, ultimately, this took us a while. It took us about 5 years, 6 years or so. I mean, obviously, in the future, we are hoping to expand it beyond dementia to look at other neurological conditions. But we got to start again. We got to start from data collection. We got to start from looking at what kind of conditions are out there, what's their frequency. In fact, in the US, I don't think dementia is the number one concern. Whereas I think in Australia or some other places, it's actually the number one concern, neurological concern. So stroke is another big thing. Dementia, depression, anxiety. Migraine is another very big condition. So these are all the different neurological conditions. But yeah, to start on any of them, you got to start collecting data. And I don't think we have done that yet. But it's possible, I think. I can at least see a world where expanding these things to addressing other conditions is feasible.
Hi, my name is Nash. I had a question about.
Turn it off.
Turn it off real quick.
Yes.
I just had a question about. I don't know if you said this in the PowerPoint, or I might have missed it, but which learning language model was utilized in your research?
So there is no language model that I have presented today.
Oh.
So a language model is the recent way of doing things. This was work published in 24, which means we actually started working on this in 22. I think if you can see what we're trying to do, language model could be used. I mean, we're actually working on them right now, but it could be used or it could be leveraged. But I think the focus here was to take all these different modalities, use something which a language model also uses, something called as a transformer architecture. That is what we have used as the core machine learning algorithm for the last work that I've done. And the predictions are more in the form of probability values. Probability of this person having Alzheimer's, probability of this person having vascular dementia, and so on. So we have not yet integrated any language model in this thing. I mean, I don't have to if I don't want to, right? So, or if I don't need to, right? So, but I can see a world where all this information can also be processed in the form of plain text summary. Perhaps language models can be useful there. I can also see a world where the entire training process can also be done with the help of a language model. But we haven't done that.
Any other questions?
Just answer to your question. You asked a very smart question on language model. There are new models are being developed. That's the next level of AI. That's where people will be saying the previous people developed this model, and that's accurate. Now we have developed this model that is more accurate. So those are the things that are coming right now. Nobody knows about AI. Nobody knows how to do the diagnosis. We want to develop the first database, how these things can be done. We're in the very ABC stage, developing any model, people are taking it and doing it. And those are the computer software engineers will be coming, going aligned with the medicine or other people to go with the medicine, if I'm not wrong. Does that make sense?
Absolutely. In fact, Dr. Bedi sitting here is a language model expert. So I think if you're interested in language models, he's the one to talk to. In fact, some of the things that he's doing is about trying to understand how these language models can be useful in a more ethical way. Right? So I think it also connects so closely with some of the questions that you're asking, which is about, if you're trying to put all these data modalities together, and if you're trying to bring language models, you want to make sure the outputs are actually ethical and not harmful, if you will. Right? So you have a UCF expert sitting right here on that.
Sure. If there are not many questions, I'm going to ask a few questions actually, because I've been patiently waiting for that. So, Dr. Kolachalama, a lot of your work is also on using AI in drug discovery. So, if you could, briefly elaborate on that. I would also like you, because we have been interacting for the last 2 days, a little bit on the AI interactive platforms you're building for medical students in Boston University, and what is that process like, how it can be leveraged for other students, and most importantly, right, so AI in that sense, when you think about AI, and as a social scientist who does technology and international security, guns and bombs, as I would say about it, there is a feeling that there's this idea of eventual AI takeover, right? In international security, it is about, what if nuclear weapons are taken over by AI, right? This is the making. But there is a real fear of human skills being taken over by AI, right? So how do you, as an educator, motivate your students to think about AI with so much of background of these very difficult questions of AI taking over some of the skills, human skills, which we have been so dependent upon? And what would make it more interesting for students to actually do medical research? A number of questions, but I just thought I'll have your take, and then I would ask Professor Singla to close it with his comments. Thank you so much.
I'll answer the hard question at the end.
Yes.
About AI taking over. I just talked about Isaac Asimov, so it's very timely. The first question is about drug discovery. I think I was just talking with Dr. Bedi as well. I think it's also, again, I talked briefly about clinical trials, but AI for drug discovery is a right area if you are interested in research and R&D broadly, AI. I think I talked about the FDA drugs for a second, right? So these two drugs were actually approved because of public pressure. Remember, I have never used those words before. I mean, have you ever heard of an FDA approving a drug due to public pressure? That's not how FDA works. But that's what happened with these two drugs. So the reason is because we don't have therapies. If somebody had dementia or somebody had Alzheimer's 2-3 years ago, you're like, okay, you know what? Good luck, stay with your family and manage. That was the situation. And in fact, for most of these other dementias, there is no therapy. If there is no therapy, what can anybody do? Right? If you have a therapy, then there is some hope, and at least the patient can see the doctor and continuously get monitored, get the therapy, and then hopefully get better. But if there is no therapy, there is nothing you can do. Most of these neurodegenerative conditions have no drugs. So there is an opportunity for AI to play a big role in drug discovery, primarily because now we have all these different systems in place where we are thinking about, for example, I don't know if you heard about something called as PubChem. PubChem is a very large open source database of hundreds of millions of chemical compounds. I mean, they include also not just biologically active compounds, they also have other chemical compounds like in pesticides, but you don't want to go there. But we are thinking about large level of virtual screening platforms that you can build to sort of really understand how these chemical properties can be evaluated using AI to see if you can really come up with drug targets. So this is a very huge and very interesting area of research where you're only not looking at computational chemistry, AI, drug discovery, and all those things put together. So I think that's a very interesting area of research. I'm happy to talk more if you're interested. We are just getting started on it. I don't think we have a lot of work done yet, but I think that's exactly what I want to talk also with Amrit. The second question is about the education.
Yeah.
Oh, that's easy. How many people have not used ChatGPT? See, there you go. I asked the question very strategically so that you don't have to do the exercise of lifting your hand. Everybody's using that. But I think there are some concerns, at least in the medical school, that if you're sending some patient data on it, it's not ethical. We don't know what ChatGPT is doing. So we thought, okay, we'll build our own platform for students in the medical school to use a language model. A lot of people are obviously familiar with ChatGPT, but they can't just download a model and then run it on their platform, right? So they want something easy to use. So we built a platform which is now currently used by all the medical school students at BU, where we created a language model that not only uses whatever is available, but also we infused these language models with additional content derived from STEM and medicine podcasts. Because if you, how many people listen to podcasts here? A few, right? So medical podcasts, STEM podcasts, Joe Rogan podcasts, there are many podcasts that are going on, but we focus exclusively on those clinical podcasts like New England Journal of Medicine, Neurology, all these very sophisticated, very well established podcasts. And interestingly, what we observed that if two experts are speaking about a clinical trial that happened yesterday and was published in a journal, they are somehow synthesizing information from those published papers, and they are trying to sort of summarize those things. And what we did was we downloaded all that podcasts, transcribed them into text, and then we updated the language models using that text. And it turned out that the updated language models are actually doing better at medical question answering. And we created this version which is now being used in our medical school. I'm happy to include all the people who are interested. And so far, if you have a .bu.edu account, you have access, but I'm happy to add ucf.edu to that as well. It's a tool, it's a free tool. You don't have to pay $20 to use it. You can just use it for free. We don't collect any data because we are not relying on your data to build the models, because we're only solely improving the models based on the podcast content. So that's why it's called PodGPT. If you can go online, it's podgpt.org. You're welcome to use it. But I'm happy to provide more information. On the third question, that's a tough one. This is my biggest struggle. I mean, today I have, how many people have heard of DeepSeek, by the way? Some of you may have heard about DeepSeek, right? That kind of changed the game for some of the things. So let's be honest, we cannot keep up with the pace of what's happening with AI. AI is moving at a breathtaking pace. What is cool today is going to be outdated in a few months. That's how it has been, right? So how do you motivate the students? How do you motivate a computer science PhD student? So you're running away, by the way. So it's very hard because you want to think about how to motivate them. And for me, fortunately, the task is slightly less complicated because I'm not motivating them to only think about algorithms. I'm motivating them to think about the questions. So especially, I think there's a lot of opportunity for you to think about, if you want to be a computer scientist, even if you want to get a PhD in CS, there's an opportunity for you to not just advance the CS or the ML or the AI part of it, but also truly apply it to a very important question. And in this case, we are looking at medicine. So I think the future is when you bring those disciplines together, whether it's AI in medicine or AI in nuclear energy or AI environment or you name it. But it has to be a combination of at least something with AI. And in fact, the purists are also thinking about drug discovery, right? Because I think Amrit is excited about drug discovery because he also wants to see that impact, right? So I think that's where the opportunity is. You don't need to necessarily learn how to code anymore. At least this is how I'm trying to teach my students, because of course it's great if you know it. There's no harm in it. But I think you need to think about how to really think about as this 10x person, which means whatever you can do today, hopefully you can do it at a 10x rate if you have AI with you. So you want to think about those questions.
So Singla, your closing comments, please.
I think we learned a lot today about AI and AI in medicine and dementia. And your last name is too big, so I will call you Dr. Vijay. Has educated us so much. It is thrilling. Pretty soon, I think AI will be in most of the things and most of the companies. I hope companies will not misuse it, the AI, the way things are. That's the only question I was having, the last question. So scientists like Dr. BJ is only working for the people, and it will support millions of people around the world. And with that, give him a big round of applause.
And to you too. Thank you so much, sir. Thank you.